started in just a minute. All right, so since it's just a little bit after 3, I'll go ahead and get started. First of all, thank you everybody for joining this conversation today. We're very excited to be here talking about how we can prevent liver cancer with the hepatitis B vaccine. Just a few housekeeping notes for everybody. Attendees are on mute since this is a webinar, but please do feel free to use the chat for any questions or to talk to one another. We also have a little Q&A box at the bottom where you guys can submit questions for our panelists to answer towards the end of the webinar. And this session is being recorded, so we will go ahead and share the recording and slides in case anybody missed anything. And I know we have a lot of new attendees at this webinar today, so we just wanted to provide a quick overview of the co-hosts for today's webinar. My name is Michaela Jackson, and I am the Program Director of Prevention Policy at the Hepatitis B Foundation. The Hepatitis B Foundation is a national nonprofit that's focused solely on identifying a cure of hepatitis B and improving the quality of life for those impacted. And so we do a lot of work in the prevention space with screening and treatment. And we also do a lot of international work as well. And then I'll pass it to my co-host, Daniel, from the National Viral Hepatitis Roundtable to do an intro to himself and his organization.
Thanks, Michaela. Hi, everybody. I'm Daniel Raymond. I'm the Director of Policy for the National Viral Hepatitis Roundtable. NVHR Program of Hepatitis Education Project is a network of patients, providers, public health leaders, community-based organizations, and advocates working to eliminate viral hepatitis in the United States as a public health threat. Very happy to be working with our friends at Hepatitis B Foundation and to see all of you today. I'll pass it back to you, Michaela.
Thanks so much. So today we're going to start the webinar with just a very brief overview and refresher of hepatitis B, and then we'll move on to presentations about the importance of hepatitis B vaccine in birth dose for children with Doctors Kevin Pan and Brian McMahon. So we'll get started by talking a little bit about hepatitis B in the current vaccine landscape.
They see you. I think if you want to be seen, you can click this.
Okay. Oh. So hepatitis B is a bloodborne virus that attacks the liver. It's often known as a silent epidemic because for most people, it has no visible symptoms, and just 25% of people in the US are actually diagnosed. So most people are actually unaware of their status, and nearly 300 million people worldwide are impacted by hepatitis B or living with hepatitis B, which makes it one of the most common liver diseases in the world. It's most commonly transmitted from mother to child, but can also be transmitted through unprotected sex and unsterile needles and medical equipment as well. 90% of babies and infants who are exposed to the virus will go ahead and develop a chronic infection, which is one of the reasons why we need to make sure that we're vaccinating babies and children against this virus. One thing that is often overlooked is that hepatitis B is highly infectious. In fact, it's up to 100 times more infectious than HIV. It can actually survive on surfaces for up to 7 days. What this means is that basically anybody can get the hepatitis B virus. You don't have to have quote unquote certain behaviors. Most people who, as I mentioned before, get the virus don't actually know how they get it as adults. They're missing key risk factors that we previously identified, which is why we should all be working to make sure that we can prevent it through vaccination. And hepatitis B is actually the world's leading cause of liver cancer and is responsible for more than half of liver cancer cases worldwide. And so before we get into this slide, I did just want to acknowledge that while we're talking about hepatitis B from a US context today, I know that there's some people on the line who might also work internationally, and access to the birth dose and the hepatitis B vaccine does remain a challenge. Many babies and families across the world are impacted by this lack of access, but there's a lot of really great individuals on the ground, including some of us here at the Hepatitis B Foundation, my colleague, Dr. Catherine Freeland, who are working really hard to make sure that people across the globe have access to the hepatitis B vaccine and the birth dose. So why are we talking about this today, and why are we here? Essentially, there's a really strong lack of understanding about hepatitis B amongst the public, sometimes amongst providers who don't really see it that often as well, about how it's spread. its consequences, why the vaccine specifically is needed at birth, and why we don't wait until later on to give children this vaccine, and just how infectious this virus is. In the United States, we've seen a significant increase in vaccine hesitancy, with lots of misinformation being spread and a lot of confusion with parents saying, which vaccine should I give my child? Which vaccines should I wait for? And so we'd like to clear some of that up today. But there's also been an increase in the state and federal level discussions about the necessity of the hepatitis B vaccine for children. I'm sure if you guys have been paying attention kind of to the news cycle the past few years, there's been a lot of conversations about hepatitis B only being a sexually transmitted disease. So why would we give it to children? Hepatitis B not really being amongst communities, so it's not really necessary. And this has really made its way up to, as I said, the state and federal level discussions, where a lot of decisions can be made that impact access to the vaccine. And finally, amongst communities in the United States who have high rates of hepatitis B, there's a lot of stigma about the virus itself. There's a fear of discrimination amongst people who have the vaccine, not vaccine, fear of discrimination amongst people who have the virus, and sort of invisibility about it since there's not a lot of symptoms. So we're not really having conversations about why it's so important to protect our communities, our loved ones, and our children against this virus. And so with that, I'm happy to turn it over to Dr. Calvin Pan to talk a little bit more about the hepatitis B vaccine and birth dose. Dr. Pan?
Thank you. Thank you for inviting me. Should I share my slide or you will have my slide up?
I'm happy to keep my slide shared for you. You can just tell me next slide.
Okay, thank you. So my mission today is to discuss the prevention of hepatitis B with vaccination. We'll talk about the evidence, why we need to do a burst dose. And finally, I will touch upon on some of the works where our team and myself have been working on how to make this prevention methods more effective. Next. So this is my conflict of interest. I have received a research grant from Gilead Science. My talk is focused on those three aspects, the vaccines, evidence, and the advances of preventing vertical transmission of hepatitis B. Next. So you just heard from the previous speaker talking about in the United States, age under 10, we still have like 18,000 infections. Those are considered new infections. You may wonder why we have hepatitis B vaccine for so many years. Since 1981, we have the hepatitis B vaccine ready for the public. And as you see in the last couple of 100 years, from smallpox vaccine to most recent COVID vaccine, the vaccine strengthened immune protection of our human being and are estimated to save over 4 million lives every year. However, why hepatitis B is still hanging there and globally is still a major challenge for public health. Next. So let's talk about how this vaccine, hepatitis B vaccine, would work. Many years of study leading to all the major organizations like WHO, CDC, or American Association of Family Practice, they all came up with quite similar recommendation and instruct us how to use hepatitis B vaccine to prevent vertical transmission, or even later on, as you can see in the adolescent population, horizontal transmission also a concern. So if you look at the vaccine schedule here, quite similar, all require within 24 hours, you should give a first dose vaccine with a little bit of variation from CDC. And CDC guideline emphasize in 2023 that all babies from mothers with surface antigen should get their vaccine within 12 hours. Of course, WHO will give a little bit leeway because the implementation challenge within 12 hours. But the other schedules, they're the same. You should get your second dose within a month or two. And then the third dose, between 6 months to 18 months of age. I like to point it out that at the end of this table and showing that the catch-up vaccine should be considered, particularly when children age younger than 18. However, for the booster dose, none of this recommendation guidelines recommend that you should give a booster dose. I think Brian, Dr. Mohan can give you more insight of it. He did a lot of study on that. Next. So the last snapshot of a global prevalence of hepatitis B is about 3% in the population, came up a total number of 258 million. But more importantly, children age under 5, the total number is about 5.6 million. So you're talking about a lot of new infections. And focus on United States, the challenge here, why we still see hepatitis B is because the delay or missing the first dose of hepatitis B vaccine within 12 hours window. And of course, some of the issue with inadequate screening of pregnant women for hepatitis B and non-compliant with vaccine schedule. So you can find many studies looking at the implementation issues eventually causing the new infection. It's not that much about the hepatitis B vaccine efficacies. Now, of course, outside of the United States, you even face a lot of challenge in resource-limited country that you don't see the availability of HPV and hepatitis B vaccine. We'll get to the HPV in a second. The hepatitis B immunoglobulin. Next. So here are the studies, major studies, talking about relatively high quality of evidence generated from cohort study or randomized control trial. Try to answer the question as when would be the good time or better timing to give the hepatitis B first dose vaccine. As you can see on highlight in the red color fonts, the incidence of hepatitis B when you compare vaccine was given within 12 hours. The incidence rate for Hep infection is about 2%, versus if you give later than 12 hours, it could be like 10 times more, at least 5 times more infection rate. So here you see those 4 or 5 major studies point to the same direction. That means you need to give the vaccine earlier, particularly in infants who born to hepatitis B mothers. And this is the greater support or evidence for all the guidelines to recommend infants who were born to hepatitis B mothers should get the first dose vaccine earlier. The earlier the better, but not later than 12 hours. Next. And if you can implement that, you can see a great public health benefit. This is the study summarized in a table from Taiwan. Taiwan might be one of the most, the first country to implement universal hepatitis B vaccine because a high incident Hep B in the area. At that time, when they implement this universal vaccination, the prevalence rate is about 15%, 10 to 15%. So, and then later on in the younger population, younger than 10 or 5, after the vaccine program, as you can see here, in 5 years or 10 years the most, then you can see a significant reduction in the surface antigen positive rate from the general population. You're talking about 90%, 80% to 90% of reduction when they implement the Hep B vaccine and HPV in about 80 to 85% coverage for newborns. Next. But I'm sure that later on you can see Dr. Mohan to share the US experience. So those are just from Taiwan. Now you may ask a question of why it's not getting 100%. Even you implement the program at 85 and 86%, but you can still see about 5 to 10% of the infection. That was because the limited efficacy of hepatitis B vaccine in certain subpopulation was so-called a high-risk transmitted subpopulation of mothers who have extremely high viral load. How would you define that? Well, basically, majority of year antigen positive mothers, if you test their viral load, they have a viral load more than 200,000 IU. That's considered a high risk of transmission. And you will see about 7% here, breakthrough on the right side, the red column. 7% breakthrough, even you give hepatitis B vaccine on time or before 12 hours after birth, plus HB. So the protection is about 90 to 95% and depends on the viral load. Of course, if you don't give that on time, you can see in the middle, in year antigen positive mothers whose infant might have 78% chance to get infected if nothing had been done or missing the opportunity. That's exactly what you could see in under-screened hepatitis B for all pregnant women. If you miss a few mothers, you didn't know that they have hepatitis B and their infant will not get HB or vaccine on time, then almost 80% of them will get corneal infection. Next. So that actually lead to my work in the last 20 years. Myself and my team were interested in finding out how we can improve the vaccine or HB efficacy and try to achieve close to 100% successful rate for preventing mother-to-child transmission. So all the way back in 2020, our team worked on a large case control study and find out that whoever failed the vaccine or HB, and we analyzed them compared to those who got a successful prevention from HB and vaccine. What we find here is they're all from year antigen positive mothers, this infant, if they got infected after the appropriate vaccination. But the transmission rate actually differs if they have different viral loads. So it's incrementally increase the transmission rate if the maternal HBV DNA level more than 200,000 IU, and the highest viral load, the higher chance to get vaccine or HB breakthrough. Next. Then we thought about the HIV model, and we will apply antiviral treatment during pregnancy. This study was done in 2022 and completed in 2012 and completed in 2015. And we published this study in New England Journal and demonstrate that if you offer mothers with TDF or tenofovir during the third trimester, in combination of timely HB vaccine and HB, then we saw zero transmission in that study. Otherwise, you have about 7% transmission, quite similar to the data that we saw before. In the ITT intention to treat analysis, it's at least 5-fold reduction of the transmission rate. So this study actually lead to most of the current guidelines suggest that mothers who have hepatitis B should be screened for viremia. If you don't have the tests are not available in some resource limited area, you should base on e-antigen data and offer antiviral treatment during the third trimester. Next. So lately, just a couple of weeks ago, we published another study, also randomized control trial, try to address some of the resource-limited country if they don't have HB, what you could do. So what we found in this study is using earlier antiviral treatment during the second trimester. That means any mothers who have a high viral load, you can start on the second trimester gestational week 16, compared to the current standard of care is offering the antiviral treatment during the third trimester with HB. The early treatment arm, actually, you do not require HB, only vaccine. You give it within 12 hours and show that both approach are non-inferior to each other. They are all acceptable with no infection occurs in the follow-up patients. That means a protocol analysis. And even in the ITT analysis, there was questionable one infant was infected because that infant lost the follow-up. But at birth, the infant have no HBV DNA, only have positive surface antigen, which is most likely from the maternal surface antigen transfusion through the placenta. Because many studies showing that without HBV DNA positivity, only surface antigen positive, the likelihood of getting coronary infection is less than 20%. Next. So to summarize my talk, the most important thing is you need to provide vaccine. Vaccine is the most cost-effective and very powerful tool to prevent vertical transmission. But however, you need to identify a subset of mothers who have high viral load. So how should we approach this? If any pregnant woman show up in your clinic, first you need to test surface antigen, or alternatively a core antibody. Then you make a decision whether you should do a further workup. If you determine this is a coronary infection, then you may first ask yourself, should I offer antiviral treatment now? If a patient have a maternal disease, which you require antiviral treatment, you start it right there and usually use TDF or TAF. Then if the mother have no indication for treatment right now, and you can wait until the third trimester and test the viral load. If it's over 200,000 IU, you still need to start antiviral treatment using TDF or TAF because they have more safety data from HIV and from HPV patients. And any kids or any newborns from hepatitis B mother should receive vaccine within 12 hours. That's recommended by US CDC. Now, how about those without hepatitis B infection? You still need to give the infant hepatitis B, a serious hepatitis B vaccine, because that will help them to prevent horizontal transmission later on. So the key is offer the vaccine within 12 hours. And if surface antigen positive mother, then the newborn should also simultaneously get the HB done, only one dose, and then complete a series of vaccine. With that, I thank you for your attention.
Thank you so much, Dr. Pan, and I'll pass it over to Dr. McMahon.
Yeah, I'm going to unmute myself and thank you for inviting me to this very important webinar. I'm going to talk about what we did in Alaska to stop transmission, both perinatal transmission and other forms of transmission. So I'll give, if I can have the next slide. I don't have any conflicts of interest, by the way. So in 1972, I was drafted and could have been sent to Vietnam. So I quickly joined the Public Health Service and as one of the, what we called Yellow Berets. And they sent me to Bethel, Alaska. And when I got there, I had been training at USC, which had a very strong liver program, and I'd been interested in that. And I I started seeing cases of acute symptomatic hepatitis in adults and children, and they all turned out to be hepatitis B positive. So with the help of the CDC and the tribal councils and communities, we did a survey of 12 villages while I was there and found that in Western Alaska, the surface antigen prevalence was 6.4% overall, but it varied dramatically as high as 23% in one village, and in another village, there was no cases. So what we did is we selected the 8 villages where they had the highest prevalence, and we followed them every 6 months, drawing everybody that was willing to participate. And we found, surprisingly to us, that those who were seronegative for all 3 markers, the incidence of new hepatitis B cases per 100,000 was over 3,000 per year. And the age of presentation was bimodal then. And when we saw that there were very few symptomatic infections under 5, but 30% of those infected under 5. Now, these were children that we had screened that were negative after birth, that got hepatitis B. They developed chronic hepatitis B. So as Dr. Pan showed, if you get infected at birth, your risk is as high as 80 to 90% of becoming chronic. But after birth, if you're infected, it can be as high as 30% of becoming chronic. And that also, we feel, differs by the genotype that's present. And there was very high incidence of hepatocellular carcinoma, not only in adults, but in children. Next slide, please. Now here's what some of the villages look like. This is on the Yukon River. They're not connected by the road system. Many of these communities, next slide. Here's one of the villages in winter. This is village actually a little bit in danger of with global warming of the sea rising, and they're talking about moving this particular village. But this is what it looks like in the winter. Next slide. So how do these people get healthcare in these very isolated villages? Well, there's a clinic. Well, here's another village which is being moved right now because it is literally out in the Bering Sea. Next slide. So in each of these villages, there are community health aid practitioners, which receive 16 weeks of training. They're certified by the state. They can do all kinds of things like give shots. They can suture. They can pull infected teeth. They can obviously look for otitis media. They work with the nearest provider via, in my days, via the radio, but now it's via Zoom. And they can prescribe drugs only when the provider, they have certain drugs they can prescribe without provider permission, but most with provider's permission. And so that's how they get care. And then I might want to say one of the reasons why we have been successful at not having a lot of transmission at birth, because we give the birth dose, as you'll see later, but also women come in a month before they're due to deliver, and they stay in the community that has a hospital and in a quarters, and then they're born in the hospital and get the birth dose right in the delivery room. Next slide. So what we found during this 4-year prospective study is that mostly transmission was occurring in these young children by open cuts and scratches. And if any of you have been in many developing countries where there's lots of mosquitoes, like in rural Alaska, and you're bitten all the time, you're scratching, you're bleeding. And so a team of environmentalists from CDC came up and they found surface antigen all over environmental surfaces. So they drew blood from a person. We didn't have HPV DNA in those days, but we had E antigen. An E antigen positive person, they drew the blood, they put it on a slide, took it back to CDC headquarters, let it sit at room temperature. And Dr. Pan referred to this. After a week of sitting at room temperature on the windowsill, put some saline on it, drew it up, stuck it into a chimpanzee, and 30 days later, the chimpanzee had acute hepatitis B. So this virus is probably infectious at least for 7 days on environmental surfaces, and likely a lot longer. Next slide. So what's unusual about Alaska is that the Western Alaska is the only area in the US that's endemic for Hep B. And in this area, the population is either Yupik or Inupiaq. Now, those used to be called Eskimo people, but now they're divided into two different groups, but racially they're identical, 90% of them. And yet there are 5 different genotypes that are located in this part of Alaska. Genotype A came from Europe. It's A2, probably from early missionaries or settlers. Genotype B is B6, which is related to B1, found in Japan. It does not have the recombination of C onto it. And it is a very low incidence of hepatocellular carcinoma. Genotype C is C2, the same that's found in Taiwan and in China. It's 1,000 years removed, but it's the same subtype. And we believe it came up the eastern coast of Asia and crossed over in Kamchatka, because C2 is also found across the Bering Sea about 50 miles away in Kamchatka. But we haven't sequenced that to see if it's identical. Genotype D, there's 2 subtypes. One came from Europe, one came from Asia. It has a much lower incidence of hepatocellular carcinoma. And genotype F1B is 20,000 years old. It came across from Asia as both genotype H and F1B, and then it split, and the H went south and died out in Alaska, and F1B also went south and is found in the Amazon and in Alaska. And it causes hepatocellular carcinoma in children. And one other thing I might want to say is that the age of seroconversion from E antigen to E antibody is the average age, the median age is less than 20 in all the genotypes except for C, where it's 46 years of age. So people with genotype C, as you see in Taiwan and China, have very high levels of HBV DNA throughout most of their life. Next slide. So what we did after all this was, we did a phase 4 vaccine demonstration project in Alaska with the permission of the tribal organizations and the IRB. And it was successful, stopping transmission in the very villages that I showed you earlier with the high rates of transmission. And then we were funded by Congress to screen the population in that area, both native and non-native. 53,000 people were screened for Hep B markers. 40,000 were susceptible and were vaccinated, and 1,500 people were linked with chronic hepatitis B, were linked to care. And then in 1984, we started vaccinating all newborns at birth and giving HBIG. And then childhood vaccinations for all Alaskans all throughout the state were started after that, with birth dose being recommended in all parts of Alaska. Next slide. So birth dose coverage in Western Alaska, we just audited this between 2015 and 2019. I submitted a paper to Lancet Global Health, which is being re-reviewed. But so I can't show you the actual charts, but basically the coverage was between 92 and 100% in Western Alaska, and the 3-dose coverage by 18 months was 80%, but it reached 100% by 2 years of age. Next slide. So this is important because I want to show you how good this vaccine is. So we've followed this original cohort that we vaccinated in 1981. We followed them all yearly for the first 10 years, then at years 15, 22, 30, 35, and we just finished the 42-year study. I can give you some general ideas about that, but it's about to be submitted for publication too. So what we were looking for breakthrough infections. Everybody that was vaccinated, they were all seronegative for all markers before they were vaccinated. And then we tested them for all serum markers. And if the core antibody was positive, they also got tested for surface antigen. Well, they already tested for surface antigen, but they also got tested for HBV DNA. And what we found is in the first 10 years, and this really pertains to parts of the world where hepatitis B is endemic, we found evidence of natural boosting. We define natural boosting as a fourfold rise in the anti-HBs level between 1 year and the next year during the first 10 years. And it was quite remarkable when these levels would just shoot up in persons, and they lived in houses where there were people with chronic hepatitis B. So natural boosting was occurring. And in addition, during the first 15 years, and none since then, we had about 20 episodes of core antibody. And a few of those patients were transiently surface antigen, and 3 or 4 of them had HBV DNA transiently at less than 100 internationals per ml. And some of them, both surface antigen and core disappeared, but about a dozen of them, the core antibody has persisted since then. We've not seen any symptomatic hepatitis. We checked all their records, both in the village and their hospital records and other records. And again, we just finished the 40-year study, and we will share that with you when it's submitted and published. Next slide. So we also looked for cellular immunity, and we picked 42 participants who had very low levels of antibody or had lost anti-HBs. And we looked for evidence of cellular immunity by doing flow cytometry with the University of Alaska here in town. On their flow cytometer, we looked for T cell and cytokine recognition of surface antigen, and it was present in every one of these 42 persons, whether or not they had anti-HBs present. So in conclusion, I think we can conclude, and this is wonderful news for the world, that if you live in an endemic area, you're going to get boosted a lot just by living in that endemic area, and you don't need booster doses. And so this is good news. We don't know about whether or not booster doses will be needed in non-endemic areas, but as Dr. Pan showed, it's not recommended at this time to give booster doses to individuals. Next slide. So what's the impact of this? Well, hepatitis B, hepatitis B was introduced. Once it was introduced, we saw that it disappeared. Surface antigen in children under 20, we didn't see any infections after about the mid-1990s that we could identify. Now, we weren't doing serosurveys, but we were looking at state records and our records, and we didn't see any cases that were reported. Next slide. Furthermore, because of the genotype F1b, children had the highest rate of hepatocellular carcinoma in the world, and that's gone away. We haven't seen it. All these kids are now grown up. There's no children under 20 that have hepatitis B surface antigen. This shows that on this slide, and the next slide shows that hepatocellular carcinoma, if we go to the next slide, has also gone away in children. We haven't seen it. We see it in adults, but not in children. Next slide. So how can we eliminate hepatitis B? We have to stop perinatal transmission. And the birth dose we really need to give, as Dr. Pan showed, and give it as soon as possible after birth. But one of the problems is that in many countries, and I worked on a project in Africa for 10 years up until COVID, the births don't take place in the hospital. So what could we do? Well, we know that and we have tried to lobby for this, and we hope that all of you can lobby for it too. And I've talked with Dr. Pan and others about this at ASLD, and we're going to talk about it more next week. But we could combine, if we could convince HIV program, because 90% of pregnant women get tested by a finger stick for HIV. And if they're positive, they immediately get put on medicine and they immediately put in the program. For $1 more, you can do surface antigen finger stick. If it's positive, you could hand that woman a supply of TDF to take throughout pregnancy and for a while after pregnancy. And if they didn't deliver in the hospital and they couldn't get the birth dose, well, that would likely prevent most infections from occurring, but that needs to be evaluated in a very careful study. Next slide. So in conclusion, HBV elimination can be achieved by a combination of universal screening and vaccination of seronegative persons. Initially, the highest risk for chronic carriage, if it doesn't occur, infection doesn't occur at birth, is in the first 5 years of life. And then introduce the birth dose, and then again, screening pregnant women for HBsAg and providing antiviral therapy during pregnancy as Dr. Pan showed with his elegant studies that he had done, of high viral loads present, and that or birth will take place outside the hospital. And I didn't mention that once we saw that there were some breakthrough transmissions that occurred in the late 1980s and early 1990s, despite the fact that we were giving HPIG and vaccine at birth, we arbitrarily decided to start lamivudine if the viral load was more than 2,000, or more than 20,000, I should say. And then we switched to TDF when it became available. And then once Dr. Pan's studies came out, we upped that level to 200,000. And that's why I think we have not seen transmission from pregnant women. The combination of the birth dose, when we can give HPIG, and the fact that we will give antiviral therapy if the level is over 200,000, thanks to the work that Dr. Pan has done. So I think those strategies will work at stopping transmission, perinatal transmission. So that's my conclusion, and thank you very much.
Thank you so much, Dr. Pan and Dr. McMahon. And so now we'll go into the Q&A portion. So please feel free to drop any questions that you all might have into the Q&A box or into the chat, and I'll turn it over to Daniel to help lead the Q&A.
Thanks, Michaela, and thank you so much, Dr. McMahon and Dr. Pan, for those really fascinating presentations. I think one of the reasons that we wanted to do this webinar series, Michaela and I were talking about how the legacy of what's been able to be achieved by childhood hepatitis B immunization in the United States extends back 4 decades now, and that period prior to the implementation of these recommendations is one that's not necessarily top of mind for a lot of people who are currently debating or speculating about, do we have the right set of recommendations? Dr. McMahon, I wanted to go back to something that you said about when we talk about preventing hepatitis B acquisition during childhood, we are concerned about direct mother-to-child transmission, but we're also concerned about young children being exposed horizontally, household, and you mentioned cuts, scratches. Can you say more about that?
Well, I think that it's wonderful what the Gates Foundation has done with the Global Alliance on Vaccine Initiative, but that doesn't start until 4 to 6 months of age. So not only does it not prevent perinatal transmission, but it also misses out on a lot of horizontal transmission that could occur either through breastfeeding, for example, perhaps, or for open cuts and scratches if the child is living in a household or environment where there's a lot of hepatitis B. And that would be a high risk for developing chronic hepatitis B. So it's really important that if a child misses that birth dose, they be tested to make sure that they're negative, and if they're negative, get them the vaccine as early as you can, even before the recommendation vaccine doses is given in many countries with the Gavi program starting at 4 to 6 months of age.
Thank you. And Dr. Pan, when we are focused on mother-to-child transmission, I think there's a lot of people who assume, oh, well, if there is a pregnancy among somebody who has chronic hepatitis B, that will be caught in a prenatal care visit, that all of that will be sorted out, and so we know which births are deliveries to a mother with or without chronic hepatitis B. But is that your experience, just speaking in the United States, or are there cases that we're potentially missing?
Well, Calvin, do you want to answer that question, or? I think you're muted, Calvin.
Go ahead. Brian, you want to address that? I can sort of after your answer, and I share my insights.
Well, I think one of the problems is I think there's a lot of misinformation that's been circulating around. I won't mention any political names, but as you know, there is one prominent person in politics right now that believes that vaccines are harmful, especially the hepatitis B vaccine, and that transmission doesn't really occur until people become sexually active or start using drugs. And I think a lot of data from all over the world shows that's not the case, obviously. Perinatal transmission, early childhood transmission is occurring. And so that really hurts when people hear that. They may not want to get the vaccine, thinking, well, my child really isn't at any risk. I think most obstetricians and also nurse midwives in the U.S. do a good job of screening pregnant women for hepatitis, but it's possible that a lot of other primary care providers don't do that. They see pregnant women, and so that means that we're not picking up some of these women, when we could do something about it.
Did you want to add anything to that, Dr. Pan?
Yeah, absolutely. I think I would like to echo Brian's opinion. Not only that, I think another issue is it's not uncommon, particularly in certain states, that a lot of pregnant women, because they may not have a legal documents data, and they would not attend any prenatal care. They couldn't even get screening for hepatitis B. They may show up in the emergency room and deliver the baby without a status of hepatitis B. It could be a missing opportunity to give vaccine or HBV, or even you give vaccine and HBV if mothers have high viral load, and chances are they still have like 7 to 10% breakthrough, particularly in United States. There are some studies showing that among pregnant women, if their age is still young, somewhere between 25 to 35, like over 50% of them have high viral load. They're still e antigen positive. So I think one reason is missing the opportunity by not screening or providing prenatal care. Definitely it's out there. I want to circulate back to the horizontal transmission. I have the privilege of working with a group of experts to write the next AASLD guideline. During the process, we actually extensively review all the data for horizontal transmission and find that there is not that many good studies to prove to document the incidence and the risk of transmission, particularly in family close contact. So what we saw is one study from China that with our very clear vaccination data and showing that there are high incidence if fraternal surface antigen positive, that they could have like 3 to 5% transmission. So there are some series of studies and small cohort study from Asia showing the horizontal transmission at the age under 10. So we believe it's true. There are risks in family contact. However, because limited data, we could not make a very firm recommendation for treatment prevention. So we may end up, you will see the guideline come out that we will ask for a shared decision making. We believe that in certain scenario, you probably should offer antiviral treatment to prevent the transmission.
So Calvin, I just might mention that I don't know, our study is so old that we conducted in the 1970s that you may not have found it, but the study is available. Let me see if I can find the actual reference for it, and I had it on my slides here. But you could, if you haven't reviewed that study, I would recommend taking a look at that. And that study was in the Journal of Infectious Diseases, if I remember right. See if I can find it here. Well, I will send you that. I will send you that reference. It's actually in it's in JID 1985 151 599 to 603. And that's the study that showed the perinatal transmission. And then the study that showed that the virus could be on a slide and infect chimpanzees is Bond et al. Lancet, March 7, 1981. Those are really old slides. So, but I think that might be helpful if they saw that information to hopefully make a recommendation about looking for that there is evidence for horizontal transmission especially early in life.
Yeah, definitely. We'll take a look at that. But I think a lot of time, some studies could not be included because they don't have control arms. You know, whether you should, you have to draw a conclusion like giving treatment versus not giving treatment can
Right.
change the outcome.
That's right.
So without that, I mean, ASLD right now is asking for guideline, which is must based on evidence base, you know, cannot be extrapolating. So that's a limitation to make a recommendation.
Yeah, that's a limitation because you can't really do that kind of study now. It would be unethical to do
Right.
kind of study. But we did, I guess, with our study, you could say that after we did vaccination in those villages, and based on our long-term study, that horizontal transmission stopped. There was no more horizontal transmission. So it's basically before and after the vaccine was available in the same population, same villages.
Yeah, definitely. It's like a historical cohort control study.
Yeah, that's a historical. I don't know whether
Right.
that would be helpful or not, but
yeah. Well, I believe, you know, if we make a consensus or guidance, we definitely can make that as a recommendation.
okay. There's somebody else, I think, Kathleen Schwartz. Hi, Kathleen. How are you? You had a question also that I saw down here. What was it? In the chat box about breastfeeding.
Well, you had commented about transmission of hepatitis B through breastfeeding. And I just wanted to say that the American Academy of Pediatrics Red Book states that hepatitis B infected mothers can breastfeed as long as they don't have mastitis or cracked or bleeding nipples. And I think it's important to know that because, of course, hepatitis B occurs in areas where infants are prone to malnutrition if they're not breastfed. So that's one of the reasons that the Academy emphasized that.
No, and I agree with that. And I think that the thing that would also really be helpful, even if the mother did have cracked bleeding in her nipples, if that infant had received at least the vaccine at birth,
right?
I think that would be an extra plus. And
absolutely,
again, pushing that would be really important, I think.
Could I bring us back to a couple of questions I wanted to make sure that people got a chance to hear if they're not following the chat. One is just very foundational. When we say birth dose, is that a particular formulation of the Hep B vaccine, or is it just about the window of timing?
I think it's the window and timing. And any hepatitis B vaccine should work. As soon as it's on label use, you know, have been tested in newborns or young kids population, it's on label vaccine for hepatitis B, it will work. It's a pediatric dose.
And is there any differentiation in efficacy between combo vaccine containing hepatitis B versus a single antigen?
Well, you obviously don't use that combo in birth. But no, there's not any that to my knowledge, there's no difference, and CDC doesn't say there's any difference. So in other words, if you give the combination vaccine starting at 2 to 4 months of age to a child whose mother was not infected and who doesn't live in an endemic area, or even if they miss the birth dose, it's just as effective. In most places now, what they're doing is giving that birth dose universally, which I think is really good recommendation. And then with the current vaccination schedule and Kathleen could comment on this, they usually end up getting 3 more doses. So often they get 4 doses, which is great. Now there is failure with this vaccine. It's about 2 to 3% failure. And we have seen a few people that have failed vaccine that ended up getting infected. We had a patient recently in a very endemic village up on the Bering Sea, and that person had failed 4 doses of vaccine. We didn't know that because we don't test everybody afterwards. And got a birth dose and presented with hepatocellular carcinoma at age 28. And was a genotype F1B. And obviously he didn't respond because he didn't have any, he got hepatocellular carcinoma. He shouldn't have gotten it if he'd responded to the vaccine. We assume he didn't respond. But there is that small group, about 1 to 3% that don't respond to the vaccine series, either at birth, starting at birth, or in early childhood. So we won't be 100% successful, but the vaccine is very, very, very efficacious, and it's a tragedy, a global tragedy, and a tragedy in the U.S. We've had this great vaccine. I know we have different formulations, but it's been present. It's been around, licensed since 1981, and yet we're 40 years later. The global number of people with hepatitis B has increased by 50 million in the last 20 years, estimated by WHO. That's a tragedy. Why can't we stop that from rising by making vaccine more widely available, especially at birth and in childhood?
Yeah, thank you for mentioning that. We did also get a comment from a nurse working in critical care who'd gone through the 3-dose vaccine series, and the titers just weren't there and needed to go through vaccination again. So apparently there's going to be a small proportion of people that need to complete a second course for one reason or another. We also got a question about the current childhood schedule in the United States. So ACIP recommends birth dose, and then a second dose within 1 to 2 months later, third dose, 6 to 9 months of age. Is there still an opportunity past that 9 months if an infant hasn't gotten that third dose yet? Or would they need to restart the series? Like, do we have a sense of the protectiveness of a more delayed or attenuated schedule in childhood immunization?
You can usually immediately give the dose that they have missed, and then test the baby maybe 1 month after the last dose. And usually you don't need to redo the whole vaccine series.
Okay, thank you. Well, I want to thank both of you, and certainly Michaela and our friends at Hepatitis B Foundation for this rich discussion. As Michaela said, this is being recorded, so we should have it up for online viewing, and you'll get notified about that. Please do feel free to share this and pass it along, and come back same time next week, next Tuesday, for the second part of this discussion, where we will be talking about how to discuss the evidence base, but also the rationale, the benefits, and the values behind childhood hepatitis B immunization in a changing, and I think it's fair to say, somewhat challenging environment. But I wanted to again thank Dr. Pan and Dr. McMahon. It's been fantastic having you here. Thank you for being such a wealth of insight, but also giving us that broader perspective that is so often lacking in some of the current policy discussions. I'm just going to pass it back to Michaela to see if there's anything you'd like to add as we wrap up for today.
No, I think that's it. Thank you so much to Dr. McMahon and Dr. Pan for being on this webinar, and we will see you guys same time next week. Have a great rest of your day.
Bye, everyone.
Thank you very much.
Thank you. Thank you all.
If you're still on, Michaela.